So good evening, everyone. Welcome to our Sage on Stage series presented by AO North America, the Hand Education Committee. I'd like to welcome all our participants, and we're going to start very shortly. We just have a few slides to go through. Tonight, our Sage is Dr. Jones, and he needs no introduction, but I'm going to give him an introduction shortly. He's coming to us from California this afternoon or evening. I'm the interviewer. My name's Paul Binhammer, and Michael St. Cyr is our moderator this evening. So if you have any questions, you can type them in the Q&A box, and they'll come to Michael, and then he can, we'll ask him for questions as we go through this evening. These are the relevant disclosures, which are nil for this session tonight. So I want to remind you about Zoom etiquette. All the microphones and videos of the attendees has been turned off. You send your questions through the Q&A box. The moderator is going to review the questions as they appear, and like I said, we'll ask Michael later on. And so please use the Q&A. And I'm going to quit out of this and save this slide for later. And I'm going to stop my sharing now. And so you should see myself and Dr. Jones. So Dr. Jones has an illustrious career in hand surgery. He trained at UCLA Irvine and Santa Monica. He's got over 270, I'll say that again, 270 journal articles and book chapters. He's had more than 700 presentations. So there's no way he can be nervous tonight. He's got this like grand slam of hand surgery, microsurgery, where he's been president both of the American Society for Reconstructive Microsurgery and ASSH. It's like a double whammy. So thank you very much, Dr. Jones. Thank you very much, and we're just thrilled that you're with us. And we're going to put you to work right away. We're going to ask you about a clinical scenario. We're going to talk about thumb Cmc arthritis. And so you see a very active 60-year-old who presents with dominant hand Cmc arthritis, and they've tried all sorts of conservative management, and they still have chronic pain. And they have an X-ray which shows there's joint space narrowing and osteophytes greater than 2 millimeters. So I think this is a little bit of a controversial area. So I wonder if you could start us off by describing your preferred treatment for this patient and how you come to that decision.
Well, thank you, Paul, for the introduction. I actually lost a lot of it, so the sound was not coming through, so I hope it's on your end and not my end. But I'd like to thank you for asking the questions, and also especially AO North America for inviting me to be the sage. So this obviously is a very controversial area, and I think it illustrates a total disconnect between what surgeons are doing in America and evidence-based medicine. So I think there are two papers in the Journal of Hand Surgery. They're basically questionnaires of hand surgeons, I think in 2010 by Shaw Wilgis, and then 2012 by Jennifer Wolf, and about 2/3, 66% in both those questionnaires were doing LRTIs, ligament reconstruction, tendon interpositions. And then maybe about 15% were doing trapeziectomies without pinning, and another 15% were doing trapeziectomies with pinning. However, I would say that there are now very, very good studies, large studies from Tim Davis in Nottingham in England, looking at prospective randomized trials of LRTIs versus trapeziectomies with pinning, and there's absolutely no difference in outcome. So if as an organization we're going to say that we follow evidence-based medicine, we really shouldn't be doing LRTIs. There's no evidence that they're any better than trapeziectomies. That being said, I personally have not done LRTIs maybe for 25 years or so. Some of the patients that have been operated on by other surgeons with LRTIs, and I'm seeing them for a second opinion, they seem to have a long duration of pain post-operatively, and they seem to be much stiffer post-operatively and have to have a lot of therapy. So I only do the LR component, the ligament reconstruction, and that's in the rare patients that you see with lupus or Ehlers-Danlos syndrome. So what do I do now? I think for the last, and this will be controversial, for the last 10, 12 years, I've been doing implant arthroplasties, and I probably am able to say which one I use. I started off using the implants from Ascension that was eventually taken over by Integra, and those were the saddle implants and the hemispheric implants. And I've switched to one now, an implant by BioPro, which is a two-component implant. So if this person is, should we say, a young 60, and he wants to try and preserve as much strength in his thumb, then I would probably offer him an implant arthroplasty. If he wanted the more guaranteed option, then I would offer him a trapeziectomy, and I basically pin them for 6 weeks. Sometimes now I'm beginning to add a mini tightrope with that. But I probably would say to him, if he's willing for me to try, then I would use an implant arthroplasty.
Does it, so your post-op regimen with those patients, do you move them early within a restricted motion, or how do you treat them post-operatively?
That's a good question. So the big problem with any implant, I think, and there are various ones on the market now, there are different ones in Europe. I think the worry is a dorsal dislocation. And if you look at, I think, the series out of the Mayo Clinic, they had something like a 19 or a 20% dislocation rate. So I tend to be very conservative, and I actually splint them or cast them for 6 weeks. More recently, I actually operated on a surgeon and did both his thumbs staged, and he was raring to go and started moving, I think, at 3 or 4 weeks. So nothing untoward came of that, and so I'm starting to slowly reduce my period of immobilization. But I have had, I think my dislocation rate is probably around 2%. I've had 2 people, both who had trauma, one who fell about 2 weeks out and dislocated dorsally, and then an outlier, somebody who was 3 months out, was reaching a suitcase on a plane, and the handle of the suitcase pushed her thumb into hyperextension, and she also dislocated. But both we were able, well, we changed their implants, and so far they're both doing fine. But I think that is it's a worry.
And do you see a role, or what is the role of CMC arthrodesis for patients who have thumb arthritis?
I tend to follow Peter Stern's advice and recommendation that this should be considered in a young person, a young working person who probably has, post-traumatic arthritis at his CMC joint. And I believe Peter, he's a great friend of mine. And so I tend to follow his recommendation. Maybe the 60-year-old would fall into that category. The new 60 is now the new 40. But I suppose you could offer this person an arthrodesis, but I've tended to keep it for a 20 or a 30-year-old working man.
So if I can take you back a few years during your training, what were the factors that created your interest in becoming a hand surgeon?
Do you have an hour to go over this? uh, it's long and convoluted, but I'll try and make it simple. You probably know that the training system in the UK when I was starting is very different. So everybody who's going to be a surgeon there has to do 4 or 5 years of general surgery. And that usually includes two subspecialties at a fairly advanced level. And then you get what's called the Fellowship of the Royal College of Surgeons of London or Edinburgh or Glasgow, just like you have the one in Canada or Australia. And then you then subspecialize, for another 4 or 5 years. So I knew I didn't want to do general surgery. I didn't want to be an abdominal surgeon. And I actually thought I would be a cardiac surgeon or a neurosurgeon, and then lower down the list, an orthopedic surgeon or a plastic surgeon. And so I did cardiac surgery and found that incredibly boring. It's, 2 operations, probably a valve and a cabbage. The only interesting bit is congenital heart surgery. And then I did a lot of neurosurgery, and I thought it was always going to be very elegant. And it turned out, apart from aneurysms and extra intracranial anastomoses, it's not as elegant as people think. And it's also, the patient population can be very, very depressing, the prognosis for some of the head injuries and even the back surgeries. So then I spent 6 months as a registrar with Philip Matthews, who probably should be recognized as one of the pioneers of flexor tendon healing research. And he introduced me to hand surgery, and I suddenly realized this is great. The anatomy is fantastic. You can see it. And then in the early 80s, microsurgery was just about to start to explode. And I thought, I have to get an entree into microsurgery. And the way to do that was to go into plastic surgery. So then I'd sort of done, neurosurgery, orthopedic surgery, plastic surgery. And I asked Adrian Flatt, what he would do if he was going to go into hand surgery. And he said, we'll come to it maybe later, but basically he said that if I was mainly plastic trained, I should work with an orthopedic surgeon. And he said the only person to train with at that time was Richard Smith. And that's why I ended up in Boston. And that's, once I got exposed to Dr. Smith, and obviously Jesse Jupiter was there just starting his practice, then hand surgery and microsurgery gave me everything. I could operate on bones, tendons, nerves, vessels. I could operate on a 3-month-old baby. I could operate on a 90-year-old. And having the microsurgery, I could just about do anything. And there's a saying, hand surgery is anything you can get your hands on. So that's how I came to hand surgery.
So it's now 30 years later, about. If you had, like Adrian Flatt, some young trainee, what advice would you give to an orthopedic or plastic surgery resident that wants to be a hand surgeon?
So I think I would still reiterate what Adrian Flatt told me. I think you need to go to a fellowship where hopefully you can get exposure to both an orthopedic trained hand surgeon and a plastic trained hand surgeon. And if you're a plastic resident, then I would say definitely go to a heavily orthopedic program. It's a little bit more difficult for orthopedic residents to get exposure to a plastic trained hand surgeon, but I think it's really imperative. And if you really want to eventually, get to be the best in your field, I think you've got to have exposure to microsurgery and become very, very proficient in microsurgery.
So this leads to this next question. So how should hand surgery fellowships manage that exposure and experience to orthopedic and plastic surgery principles and techniques, especially as you indicate that it's possible that programs may be challenged either in one way or the other way. Do you have any advice to programs in that?
Well, far be it from me to give advice to programs. I think there are several of us, and it was part of my presidential address. I think microsurgery is not being as well taught in America as it is now in lots of other countries, especially Asian countries, India, China, Korea, Japan, Taiwan. And I think we're falling behind a little bit. It may be due to the training, but it may be due to lots of other factors like lifestyle, reimbursement, even the medical legal climate. But for a young person, I think it's imperative that they try and get exposure to both the orthopedic and the plastic surgery side. And so programs really need to become combined programs, completely collaborative between the two parent specialties. And obviously there's money involved and there's reputations involved. And so there are some programs that are totally combined, and there are some that are very stringently one or the other. But I think the best programs are combined, and hopefully in the future, more programs will adopt that concept. And hopefully in the future, we'll see much better microsurgical training.
So do you think microsurgical training should be, and I'm going to use this word, a mandatory, like a microsurgery course, should be a mandatory part of fellowship?
Absolutely. I think absolutely an orthopedic resident going into a hand fellowship should do a 1-week microsurgery course, but that's not enough. I think they've got to go to a lab in their hand fellowship program institution and hopefully, you know, every week do a couple of hours, as well as hopefully being exposed to microsurgical operations within that fellowship program. And similarly, I think it's important that a plastic trained resident coming into a hand fellowship do an AO course before they come into a fellowship program. Although obviously with craniofacial surgery, I think now plastic residents have more concept of AO principles than, you know, even 10, 20 years ago.
Do you think, so this is the last hand fellowship related question. Do you think hand surgery residency in the US is a possibility within the near future? And is this a good idea or a bad idea?
I think
I'm trying not to get you into too much hot water.
Right. Again, this is very diplomatic, but I think Bob Szabo, when he was president of the Hand Society, I can't remember what year, but he had the idea of developing hand surgery as a specialty and as a independent residency right after you've done, you know, your first year of internship. And as part of that, there would be, you know, a hand surgery board and a board examination. But I don't think it got very much traction. And I personally don't think it's a good idea. I think there are programs around the world where it has been instituted, and Singapore is the classic example. And there they do a hand residency. And many of the Singaporean hand surgeons are incredibly well trained in both the orthopedic and the plastic surgery side of hand surgery. But I think it has limitations in America because many hand surgeons will, if they're orthopedic, they'll go into an orthopedic practice, and that orthopedic practice will want them to take care, let's say, of tibial fractures, you know, one day a month or something like that. And if they've done a hand surgery residency, they're not going to be able to do that. They're not going to be useful to that private practice. And you can apply that same limitation to a private practice plastic hand surgeon. he's not going to be able to make up some of the money by sewing up lacerations of the lip in the emergency room. So I think it's a dead issue in America, but I may be wrong.
So let's see if Michael has any questions. Michael, are you there?
Yeah, we have a question from Peter Remick. Peter asks, Dr. Jones, the history of implants for CMC osteoarthritis has been pretty difficult and challenging. What do you feel about your results? Are they good? Is this based on a new design, a new technique? Or is there another factor that has increased your success given the difficult history of CMC implants?
Well, I totally agree with the question that it's had a controversial history, no question. I think the implants have improved, and I started fiddling around with implants when there was a ceramic, like a marble, a little ball, which was called the Orthosphere. And the first few patients I did had remarkable results clinically, and they needed very little immobilization. They had excellent function. But if you looked at their x-rays, and there was a paper that came out looking at, I think, 8 patients or so, then you'd start to see this erosion and lucency, or lucency first and then erosion, both into the base of the metacarpal and then into the trapezium. So I stopped doing that after that paper. And now I always thought that the best implant was an implant that was called the saddle implant, which just had a stem that went up the thumb metacarpal. You did nothing to the trapezium, and then the saddle sat on the remaining, for what is called the cartilaginous remaining surface of the trapezium. And those patients did extremely well, and you saw very little lucency up in the thumb metacarpal. But then that implant was taken off the market, and I don't know why. I think it was probably because of low sales. But certainly some surgeons that were doing them in Europe had similar experiences I did, and were very pleased. And then and so after the saddle was taken off, I switched to this other company called BioPro. And the BioPro is a 2-component system, so you can have different sizes for the stem and this hemispheric implant that sits like an acetabulum in the trapezium. And I tend to take as little of the trapezium as possible, and I try and sit the implant as palmally as I can, and also as ulnarly as I can. And then I really take a lot of effort in recreating or reconstructing a dorsal capsule. And so far, we're out at about, I think, either 11 or 12 years. And as I say, the only 2 dislocations I've had, and I've had to remove one for excessive bone formation around the trapezium and the base of the metacarpal. This woman had a propensity to develop ectopic calcification in other joints, and she did the same thing with the CMC joint. So I just tell the patients, you know, this is still experimental. I say the fallback is, if it goes wrong, you take it out and just take out the trapezium. So apart from having a little bit of shortening of the thumb compared with doing an initial trapeziectomy, I don't think there's much downside.
Great. Thank you. I think that answers Peter's question very well. Thank you, Dr. Jones. Have you made any modifications to your technique, you know, over the last 12 years, or it's pretty much standardized since the very beginning? Have you had any little caveats that you could share with the audience in terms of things that you wouldn't do anymore to improve success?
I think the main ones are Well, I think the two main ones are once you put any implant in, and I think it applies to all the various implants, you have to move the thumb into adduction and abduction and make absolutely sure that there's no impingement between the base of the thumb metacarpal and the remaining rim of the acetabulum of the trapezium. And if there is, then you have to, use a rongeur or an oscillating saw to remove that impingement. And now the beauty with this two-component system that I'm using now is you can actually increase not the size of the head, but the length of the head or the depth of the head. So you can actually expand the long axis of the thumb metacarpal in a way, and you can prevent that impingement between the bone of the thumb metacarpal and the trapezium. So that's key. And then the other one is that dorsal capsule and that periosteum on the base of the thumb metacarpal. You've got to keep that as thick as possible, and you've got to try and get a really tight closure of that to prevent a dorsal dislocation.
Yeah.
And what I do now is I actually drill 2 holes in the base of the thumb metacarpal dorsally, and I advance part of the APL tendon and the dorsal capsule. So again, I'm tightening that into extension at the CMC joint. And I'm very careful to tell the patients not to do any passive flexion, just do active flexion for 3 months before they do any passive flexion, and tell them that it will feel tight and it'll gradually loosen up over time.
Great. Thank you very much. Thank you.
That's great. A history of success. Yeah. 12 years, you said.
Yeah.
Super. So I'm going to ask you a different clinical scenario now. And I wondered if you could discuss some perspectives on the management of a case that involves a humerus fracture. So a 30-year-old is referred 6 months after mid-shaft humerus fracture. The fracture was plated, and the surgeon noted that there was a divided radial nerve with a 10-centimeter gap. So can you tell us how you would manage this patient as he presents now with a radial nerve deficit, and particularly with regards to the variables of age, time since injury, and the nerve gap distance affect your decisions in surgical management for this patient?
Well, it's a great question, and it's probably for all the residents and fellows, it's something that you're probably going to get asked on your boards. So I think probably there's a failure of treatment right to begin with. Why is this person 6 months out and nothing's been done? And probably if the fracture was being plated and there was a 10-centimeter gap, then you could make an argument at that stage, this person's only 30, let's graft this at the same time. If you don't do that, why don't you consider tendon transfers even before 6 months? But to take the question as it is, I think it's pretty well acknowledged that the success of a nerve graft is really dependent on three factors. One being younger than age 20, so probably everybody listening in is over the hill. 2, probably the nerve graft should be done within 3 months of the injury. And number 3, the nerve graft, or the nerve gap rather, should be less than 5 centimeters. So even at 30, this man is over the hill, theoretically, and the nerve gap is 10 centimeters. So what I would do to him, I would say, first of all, wear a splint on your wrist just to cock your wrist back 20 degrees. I don't use those dynamic outriggers for the fingers. They look fancy, but nobody uses them. They're too clumsy and cumbersome. And then I would say to him, there are probably 3 options for you. Number 1, we could go back and nerve graft you, but 10 centimeters is a long graft, and you're 6 months out and you're 30. but it's a possibility if you want to consider it. It will probably take you, upwards of 9 months or a year to see some restoration of wrist extension and finger extension. Number two, I would say we can do tendon transfers for you, and those are much more guaranteed. And I tend to use standard Watson-Jones transfers. So I use pronator teres to ECRB. I use FCU, not around the ulnar border, but through the interosseous membrane to EDC, and then I reroute EPL onto the volar forearm to palmaris if they have it. And then I would say, excuse me, number three, there is some interest now in nerve transfers, and we could potentially use some of the nerves that normally supply muscles in your anterior forearm supplied by the median nerve, switch them to the nerves that control wrist extension and finger and thumb extension, and wait maybe 9 months and see if we get re-innovation of those muscles. But I would probably try and push him towards tendon transfers, because you can get back function, within 6 to 12 weeks of the surgery. And it's relatively guaranteed that you can get, I think, very, very good results of wrist extension and finger and thumb extension.
So you would push quick functionality and certainty.
To me, yes. If it was me as the patient, I would want that rather than something where you're guessing on the result and the result is not going to come for 9 months to a year. And it's just like free flap surgery. Sometimes the great majority of free flaps work, but if you're that 1 or 2 or 3% where a free flap fails, you have 100% failure. And I think you have to look at a nerve graft of 10 centimeters and even the nerve transfers. There is the possibility of 100% failure. So now you're a year down the road, and now you have to consider tendon transfers. So if you're willing to waste a year of your life, then by all means go ahead and do that.
So this sort of segues into the next question, which is during your years of practice, what are the biggest changes you've seen in hand surgery exclusive of microsurgery?
That's interesting. I recently gave a lecture on entitled Operations I No Longer or Rarely Perform, and it's amazing how many, I think I had 16 or so, and that segues a little bit into your question, but there've been unbelievable changes in hand surgery. I would say, and I'll just mention a few, but if you think about rheumatoid hand surgery, that was incredibly common. I would do, maybe 1 or 2 PIP or MCP joint implants every week with Dr. Smith. And now it's a rare case. You may do 1 a year, maybe if you're really lucky 4 a year. And many, I think many hand fellows rarely see these PIP and MCP joint arthroplasties. So that's been revolutionized by, the various pharmacological agents for rheumatoid. I've been through the entire pendulum of distal radius fracture treatment. I was in at the start of K-wires and plaster. I was in the era of external fixators. I was in the era of dorsal plates and pie plates. And now we're, with volar fixed angle locking plates. So I'm sure there's going to be another pendulum swing in another few years' time. Internal fixation devices have changed for the better. We have headless screws for scaphoids and 4-corner fusions. We have, low profile dynamic compression plating and lock plates. I think nerve transfers have come along, and I think they don't work all the time, but I'm very impressed by the Oberlin transfer for a C5-6 brachial plexus. I've had some spectacular results, and I've had some total duds. And the same thing with using the terminal branch of the anterior interosseous nerve for the motor branch of the ulnar nerve. Again, some unbelievable results, but some complete failures. I think Dupuytren's has changed. I think still I do a lot of Dupuytren surgery, but I think in some people you can get excellent results with needle aponeurotomies, and obviously collagenase has come along. I think wrist arthroscopy is a massive improvement certainly for diagnosing wrist pain and maybe sometimes treating it. And then even things like the evolution of myoelectric prostheses has changed, you know, for patients with amputations, and certainly forearm amputations. So that's a quick trip, I think, through things that have changed.
That's such a great response, because it shows how dynamic the specialty is. And if you're just sitting at one point in time, you don't have that perspective of that, in fact, it is a truly evolved.
Sorry, I think I've lost you.
Hey, Paul, we lost your volume.
I'm still here.
Got you back.
How's that?
Yes, that's great.
Well, I just thought that was such a great answer, because hand surgery is just, if you just are sitting in it, you may not appreciate how dynamic it's been and what an evolving specialty, and it keeps you on your toes.
Absolutely. And the residents and the fellows keep you on your toes.
So how important has microsurgery been to the development of hand and upper extremity surgery?
Well, again, at the risk of offending various of my friends, I personally think that, and I think I said this in my presidential address, I think antibiotics is probably the #1 advance in hand surgery. And the #2 advance, or certainly the most important advance since antibiotics, has been microsurgery. And lots of people say, oh, that's ridiculous. You know, what about plates and screws and distal radius volar plate locking plates? That only treats a it treats a lot of patients, obviously, but it only treats a minute area of patients' problems in the hand. And if you look at microsurgery, it has really revolutionized lots of different areas of hand surgery that before would almost certainly result in either an amputation of the upper extremity or complete loss of, let's say, sensation and a totally non-functional upper extremity. So that would be my argument why microsurgery is the #1 advance after antibiotics.
And so where have we failed to significantly progress hand surgery, or conversely, where do we really need to push research to improve outcomes in hand and upper extremity surgery?
Can I just go back to the last question just to emphasize something?
Yeah.
Before I get an irate text from somebody. I mean, if you look at microsurgery, in terms of replantation and revascularization, you can get spectacular results now of, you know, radiocarpal amputations, multiple finger amputations, even amputations up at the elbow. Free flaps for coverage of trauma, both in the upper and lower extremity of salvaged extremities that are very functional. Free bone transfers, vascularized fibular transfers have revolutionized not only trauma, but more importantly, tumor resections. Now you can salvage arms and legs for that matter, with vascularized fibular transfers. And then in brachial plexus, you can use vascularized functioning free muscle transfers. And then just in the whole gamut of nerves, just using the microscope, just group fascicular nerve repairs or group fascicular nerve grafting. And then obviously nerve transfers have grown out of using the microscope. And then obviously toe to hand transfers, not only for amputations, but for congenital children, or for children with congenital deformities. To answer your question, where have we failed? I think it's not a failure of the surgery. I think where we failed are probably three big areas. One, we as hand surgeons do not have the research to learn about modulating scar formation after any hand operation. So any hand operation that you can do can be totally disrupted by scar formation. And obviously everybody thinks of flexor tendon repairs, but even if you put a plate on, on a proximal phalanx or a metacarpal, you poor range of motion just because of scar formation. So if we modulate that, we would improve our results remarkably. Number two, I think we have got to the limits of nerve repairs under the microscope, and I think the future again is going to be more molecular biology research or pharmacological research where we can use nerve growth factors, maybe with intubulation, and somehow direct the motor axons to the correct destination and the sensory axons to the correct destination. And then I think even more importantly, the future will be an interface between the end of a nerve and maybe some computer application, so that there's an amputated or a neuroma nerve that somehow then controls a dynamic prosthesis. So I would say scar modulation, nerve manipulation, and then the nerve computer interface.
Oh, sounds great. I can't wait to get there.
We may not be there we may not be around when it comes.
So I'd like to ask you a question sort of outside of hand surgery. It's a clinical case of a 25-year-old who's 4 months following a motorcycle resulting in a knee dislocation. And he has no fibular nerve function clinically or on EMG. And I wondered what your approach is to patients with fibular nerve injuries associated with knee dislocations.
Well, obviously, it depends on whether you as a hand surgeon get consulted on a knee dislocation, but certainly for the residents and fellows, the common perineal nerve is the most frequently damaged structure with knee dislocations. And you can see incidences up to 40% of knee dislocations. And so I personally believe that hand surgeons are the best surgeons to repair or reconstruct a nerve. And so this is a pure example of anything you can get your hands on, and I think you're the right person as a hand surgeon to deal with the perineal nerve. So in this clinical scenario, I think you're absolutely obligated to explore the nerve to try and delineate the mechanism of injury. And the mechanism of injury could be something as simple as just displacement of the fracture of the fibular head or the neck. And if you can, obviously then the knee surgeon can fix the fracture and you can separate the nerve and maybe get, complete return of function. You may have, because of a hematoma or swelling, you may have just a compression of the nerve as it enters peroneus longus. And again, just a simple decompression may restore nerve function. However, I think there's a pretty high incidence of a stretch mechanism, and the nerve, the common perineal nerve, is obviously in a way fixed at 2 points at its origin from the sciatic nerve and then where it enters the peroneus longus. So you can have stretches, 7-10 centimeters long, and if the nerve is intact, there's not much you can do because you can't really delineate the extent of the injury. And then obviously the nerve can be ruptured both serially from the sciatic nerve or inferiorly at the peroneus longus entrance, and then you might be able to do some sort of nerve grafting. And then I think the next step is whether there are nerve transfers, taking a fascicle from flexor digitorum longus and flipping it into the motor nerve to tibialis anterior. I think that is in its infancy, but I think that's something that might be considered. And then the standard obviously is if you see a tremendous stretch injury or a complete rupture that requires a long segment of nerve grafting, then the conventional treatment is tendon transfers, where the foot and ankle surgeon switches tibialis posterior to tibialis anterior.
Right.
But I think the answer to your question is probably we should be involved as hand surgeons in doing most peripheral nerve surgery, and in this particular scenario, we should explore the nerve and try and delineate what's gone on with the nerve.
Thanks, that's great. So I wonder if you could put into perspective hand surgery and microsurgery on a global perspective. And because you sort of alluded to studies elsewhere in the world and how we learn from each other, and importantly, how we discern what will work in our own part of the world when we read the literature or hear from international hand surgeons.
So I think I've alluded to this already. I think certainly in, should we say, bread and butter hand surgery, we can hold our heads high with any other countries around the world. I think and I don't think it's just me, but there are several other people in the hand society who believe we have maybe fallen behind in the microsurgical applications in hand surgery compared with, as I say, India, China, Japan, Korea, Taiwan. And it's not just those countries that have these high volumes. It's even going to countries like Vietnam and Thailand, which are supposedly underdeveloped, where their level of microsurgical expertise in, let's say, brachial plexus reconstruction, certainly salvage of upper and lower extremities, and toe transfers, all those, we don't compete with them in terms of volume and in terms of the latest advances. So I think I've always believed that that we have a lot to learn. American surgeons have a lot to learn from other surgeons from around the world, and whether it's from India or China or Thailand, we should be receptive to these surgeons. And when I was president of the Hand Society, I mandated that every panel and every instructional course should have an international member as a panelist. And it was interesting. I got a lot of backlash for that, but I really believe we learn as much from them as they learn from us. That being said, there are some things that are done in China or India or Japan or Korea that may be too much, let's say, for either American surgeons or American patients. And again, that may be related to the medical legal climate. But for instance, there are, let's say, a cross C7 brachial plexus reinnervation is done by a few people in this country, but may not be accepted by a lot of surgeons or even patients. Double toe transfers, second, third toe transfers can have remarkable functional results, but it's very hard to convince an American patient to give up his second and third toes. And then even things like, probably the best results for brachial plexus are doing operations like the Rambo operation, doing, double free muscle transfers. And again, obviously, Alan Bishop and Alex Shin are doing them at the Mayo Clinic. And I think you guys do them in Toronto, but again, there are very few surgeons who are willing to do them in America, and patients who are willing to undergo them. So I think we definitely learn from hand surgeons overseas. Some of those we can adopt. Some of them may be a little bit too pushing the boundary for American surgeons or American patients.
So part of your career has been an interest in global health as it relates to hand surgery. How has this sort of personally impacted your career?
Well, that's hard to answer. I think I've always been interested in passing it on or giving it back, and that really pertains mainly to teaching orthopedic residents, plastic residents, hand fellows in this country, in America. But I think we also have an obligation to give that expertise or pass that expertise on to other countries where there may be no hand surgeons or no hand surgery expertise. Obviously, that's going to change as time goes on, but there are lots of countries where there are no hand surgeons. And so, for example, Cambodia, and I was introduced going to Cambodia by the Dr. Smith's fellow after me, Graham Gumley, who's an Australian hand surgeon in Sydney, and who had worked in Cambodia just after after it was opened up after the Vietnamese occupation. So I've been going with Graham to Cambodia, to Phnom Penh, for maybe 12 years now. And then I started going to other countries and teaching and operating. And for example, last year I went to Cambodia, Nepal, Jordan, and then I spent a week in the Vatican. So 4 different weeks, and maybe in those 4 weeks I probably benefited certainly a few surgeons in those countries, but I probably benefited them learning how to do an operation more than maybe 48 weeks back at UCLA. So it's all a question of passing on the ability to do maybe just very simple operations. But if you look at Cambodia, we started teaching very simple operations like ORIF of fractures, tendon repairs, nerve repairs, release of bone scar contractures. And as those local surgeons become more proficient, then you can take them on to do, a 1-bone forearm or a policization, or even now microsurgery. And so you can, in a way, if you're going over a year and you're maintaining follow-up on those patients, you can almost build a type of residency in another country, even if you're going just 1 week a year.
Wow, that's great. So do you think there's a role for global health in hand surgery fellowships?
That's another controversial question. I think by that you mean, should we be taking fellows on missions? And I have some very definite thoughts on that. Yes, we can take fellows, and we actually do. We take you know, one fellow to Cambodia, sometimes two. And I took a fellow to the Vatican, but I think they need to be, their role is as an assistant or a teacher, and probably their most important role is as a teacher, because they have you know, very ready-made empathy and association with, let's say, the young residents, far more than an old guy like me. And so they can, you know, give very simple lectures to those young trainees in that particular country. But where I have big ethical problems, and it applies not just to hand surgery, it applies to other things like cleft surgery. Our main goal is to teach the local surgeons not to take a fellow to Cambodia so that he can do a policization, if you get my meaning.
Yes.
And that's where I have really grave reservations. And then as we've actually, in Cambodia, for instance, we take now sometimes 7 or 8 hand surgeons, upper extremity surgeons, and I think 2 or 3, yeah, maybe 2 or 3 or even 4 of the current 7 or 8 are people who are fellows with either Dr. Gumley or myself. And so, you know, one's from Australia, one's from Thailand. So in a way, it's an inbuilt training, and by coming as a fellow, they see the attraction, and they're then much more qualified once they become an attending, and then they become part of the team again.
So I think we have a couple of follow-up clinical questions. I'm going to turn it over to Michael.
Dr. Jones, one of the questions comes from
Sorry,
this actually follows. Sorry. So this comes from Emil Denisian, who's asking, how do you think that hand surgery education and fellowship will evolve in the future?
Sorry, you broke a little bit, so I missed part.
How do you think, Dr. Jones, that hand surgery education and fellowships will evolve in the future?
In America or elsewhere?
You know, two-part question: in America and also internationally.
Right. So in America, I think hopefully they will see the attraction of combining orthopedic surgery and plastic surgery, so that fellows get access to or expertise from both of the parent specialties. I would hope that people will see the necessity of microsurgical training and hand fellowships. Not everybody has to go out and do replants, and in any case, the volume of replantation is going way down in a lot of developed countries, not just America, but also Europe. And I think other than that, it will be more a question of whether hand fellowship, and for that matter, any fellowship training, is going to be paid by the government. That will have repercussions, and how many years of postgraduate training will be covered by the government. If that come in, then that will have significant repercussions on people doing hand fellowships, or for that matter, other fellowships. But it may mean that we are training less hand surgeons than we are currently. In terms of other countries, in terms of other countries, there are obviously extremely good fellowship programs in other countries, and some Americans go to those fellowships to get even more training than, let's say, their 1 year in America. And actually, for that reason, we developed the American Society for Surgery of the Hand International Hand Surgery Fellowship. So every year we have selected 3 young superstars, American trained hand surgeons within 5 years of doing their fellowship. And then 2 of them go to China for 3 months and 1 goes to India for 3 months. And basically, India and China have very, very high volumes of hand surgery and microsurgery. And so those international hand fellows actually are able to operate in China and India as an assistant, rather than the usual fellowships like the Perineal fellowship, which is just for meeting people and lectures. And so the 6 ASSH international fellows that have returned have already transferred some of the expertise that they've learned from India and China back to their parent institutions. And I hope that we'll continue that and continue the funding for that, because that will also help in the future development of microsurgery and hand surgery in America.
Perfect. Thank you. Great.
So I have another question here, and it relates to the perineal nerve injury. And Dr. Chai Mudgal asks, does he have a limit of gap that he will graft on a common perineal nerve injury in a knee dislocation?
Well, obviously, I'm going to go against what I've told you. I think the answer is anything over 5 centimeters, and that's borne out, I think, by some of the studies on the perineal nerve. Anything over 5 centimeters is like tossing a coin. And as many of these are very difficult to determine the extent of the injury, and some of them are actually ruptures from within the sciatic nerve, then I think while you're there, you probably have to do some sort of long graft, but I think the chances of success are very, very limited. So I think to answer the question, when you're there, you make a decision as to whether you can define the injury. And if you're there, you graft whatever it is, whether it's 3 centimeters, 5 centimeters, 11 centimeters. But as you go from 3 to 11, the chances of any recovery drop off dramatically.
So it's been an hour, but it seems like it's gone really quick. Do you have any final thoughts you want to pass on, let the audience know?
No, I think hand surgery is definitely a fabulous specialty to be in, because you can do so much. And I don't think it's standing still. I think there are going to be developments from the time you finish a fellowship to the time you finish your eventual career. And it's just a question of being able to go with the flow and not just be restricted by the 10 common operations that you were taught in fellowship. And hopefully you will evolve as I have it, and as I'm sure have you. And I think it's a specialty where we still need a few people to keep pushing the boundaries, because if we don't push the boundaries, it's going to get boring.
Yeah, I agree 100%. So thank you.
Didn't ask me about the ulnar nerve, but that's fine.
Well, I'm happy to ask that one last question. You want to hit a home run? So this is one last clinical case for us. It's a 40-year-old who sustains a clean laceration 10 centimeters proximal to the cubital tunnel. It's easily repairable. What is your approach to the anterior interosseous transfer in this situation?
So, the man is 40, over the hill. The location is 10 centimeters above the elbow. So that means even if you repair the nerve, the chances of reinnervation of the intrinsic muscles of the hand are going to take well over a year. And even with the best repair and the fastest possible reinnervation, by the time the reinnervation gets to the hand, the motor end plates have degenerated. So I would definitely repair the nerve. I don't think I would not repair the nerve. I would splint the elbow for 3 weeks to stop any traction on the repair itself. And then at 3 weeks, I would put the patient in a low profile lumbrical block splint. So I would block the MP joints at 70 or 90 and allow him to extend the IP joints. And the reason I do that in all the nerves is it tightens up the MP joint volar plate, and it might just prevent clawing of the fingers if you institute it early and you continue it for many, many months. And then at about 3 months, I would check on whether he has any return of FDP function to the small finger or to the ring finger. If he did, that's indicating that my repair is working and there's some reinnervation of the proximal FDP muscles. But I would tell him that he's not going to get back intrinsic function. We might be able to prevent the clawing with the lumbrical block splint, but I would talk to him about a nerve transfer of the branch of the anterior interossei to the pronator, and then coapt that to the motor branch of the ulnar nerve. And if I was going to do that, I would do it end to end. I don't think there's anything to lose by going end to end, and there's probably more to gain. But I would tell him, again, it's not quite like tossing a coin, but it may work spectacularly, and it may not work. So that would be my treatment for him.
And so in follow-up, do you see the AIN supercharged end to side transfer in other clinicals, that not direct repair, but end to side? Do you use it in other clinical situations?
I have done a few end to sides, and again, end to side is controversial compared with end to end. But the ones that I may consider it in, if you have a little bit lower laceration, let's say in the proximal or middle thirds of the forearm, then I will repair the ulnar nerve and then talk to them about doing an end to side at a second stage, not at the same time. And so that's one indication. The second indication, I see a fair number of people with failures of cubital tunnel releases. And if you're seeing somebody second or third time and they have, intrinsic weakness or intrinsic atrophy especially, then if that person is relatively young, you may think about doing an end to side AIN to the motor, where you think the motor branch of the ulnar nerve is. And similarly, there are some patients with terrible diabetic neuropathy with intrinsic atrophy, where I think that they may be a candidate for the same sort of thing. Release their carpal tunnel, release their cubital tunnel, and at the same time do an end to side babysitter. I haven't done it yet, but I'm thinking about it.
That's great. Thank you so much for this evening. It's very much appreciated and very well received.
Well, thank you for inviting me. It's been fun doing it. A lot of controversial questions, and probably I'm going to get lots of angry emails and text.
So just for the audience, I have a few closing slides. And I'm just going to share these. So we still have one more sage on stage, and that's in 2 weeks' time. Doug Hannell is going to be our SAGE. And you can access the recording. A link's going to be set out through in 24 hours through Zoom, and you'll be able to see the contents of this. And we have a YouTube channel. You can't claim CME credits for recorded events, but you can if you were here this evening.